Hey everybody, welcome back to Ortho Nugs. In this video, we'll be going through some shoulder complex joint mobilization techniques. We know the shoulder complex includes not only the glenohumeral joint, but also the AC, SC, and scapulothoracic joints. Let's do it. Let's begin by assessing passive joint play of the glenohumeral joint, thinking about the orientation of the glenoid. So we're gliding posteriorly and laterally, assessing the amount of glide and springing against the barrier. Now we're doing an posterior to anterior, again, springing against that tissue barrier, and then a caudal glide. Now we move on to treatment. I place a rolled up cuff weight on the posterior aspect of the distal lateral scapula to provide a counterforce. I'm applying an anterior to posteriorly directed force. This is more of an oscillatory mobilization or a Maitland mobilization, springing against the barrier. We begin in the open pack position. I can then move to a point in the range that is more restricted and also do a posteriorly directed glide. You can see an oscillatory mob and now more of a sustained mobilization force. We can also do a caudal glide. So we're palpating for the lateral aspect of the acromion, moving just lateral to that to assure that we're on the humeral head. I'm in the open pack position again, inferior gliding, oscillatory mobilization against the tissue barrier. We can start to move away from that open pack position. Now we're at 90 degrees of abduction, so pre-tensioning the inferior capsule of the glenohumeral joint and gliding inferiorly. Oscillating against that barrier, and then we can move into even greater degrees of abduction and mobilize in that position. So a nice way to progress these stretch mobilizations by moving away from the open pack position. This is more of a sustained mobilization force. Now we're going to incorporate internal rotation stretching, so pre-tensioning the posterior capsule and combining that with a posterior lateral directed glide of the humeral head. You can see an oscillatory mob or a Maitland mobilization grade here. We can put the shoulder into a bit more internal rotation and then again apply that posterior or posterior laterally directed force. This is more of a sustained hold. Now we're going to try a lateral distraction technique using a belt. So we'll put this mobilization belt as close to the joint as possible. This is the point in the video where I struggle to find or adjust the belt to the correct length. And there, looks like I've got it. All right, so as close to the joint as possible. I'm using my left hand as a counterforce to prevent her arm from being pulled or humerus from being pulled into horizontal abduction. And then using my right hand to stabilize the lateral aspect of the scapula. So distraction force, I tend to prefer more of a sustained mobilization force as opposed to oscillatory, and that's usually the reason for that is patient comfort. They tend to tolerate a sustained hold better than that. If the band or the mobilization belt is cutting into the patient's proximal arm, then we can add a towel. And same idea, I can put her into a little bit more horizontal adduction to further tension the posterior capsule and then apply that lateral distraction force. Now we're going to move the patient into prone, again using that rolled up cuff weight to create more of a firm stabilization counterforce on the lateral aspect of the scapula. Got the patient in the open packed position, palpating the posterior lateral border of the scapula to, again, nice, easy to find osseous landmark to assure that I'm on the proximal humerus when applying my mobilization force, oscillating against the tissue barrier. As we've done with other mobilizations, we can pre-tension the anterior aspect of the glenohumeral capsule by putting the shoulder in a bit of extension, moving away from that open packed position. I can also incorporate some external rotation stretching, moving close to the external rotation range of motion barrier and then applying an anteriorly directed force. You can see an oscillatory and then more of a sustained Kaltenborn mobilization technique. Now we'll do some scapular mobility. So I place a pillow just to create an extra barrier. You can also add an additional pillow on top of her arm if you want to create another barrier between you and the patient. I've got my right hand on the inferior aspect of the scapula. The inferior aspect of the scapula is in my first web space. And then I'm grabbing the superior aspect of the scapula, spine of the scapula, to mobilize into retraction, protraction, do some upward rotation, downward rotation of the scapula. I can also change my arm position to use the humerus as a bit more of a lever if I want to create more upward rotation of the scapula. So just a slight variation on patient positioning for this upward rotation scapular mobilization. So the shoulder complex also includes the AC joint and the AC joint. So we're moving laterally along the clavicle, finding the AC joint, or it's the articulation of the distal clavicle with the acromion. So with my left hand, I'm palpating the AC joint. I'm going to get a hold of the clavicle. Ideally, we want to be as close to the joint as possible, but with the anterior aspect of the deltoid and the upper trap fibers, sometimes it's a little difficult to grasp the clavicle. So you can see I'm a bit away from the joint, but I can still feel that there's mobilization or mobility at the AC joint. Now we're looking at the SC joint. Again, palpating with my right hand, applying an anterior to posterior and then a posterior to anterior mobilization force with my left hand. I can then change my position to do an inferior glide of the distal clavicle. So I'm palpating the AC joint with my right hand. Left hand is applying a mobilization force. So I'm using the pad of my thumb and also the dorsum of my second digit, the middle phalanx of my second digit. Same thing with SCJ, palpating with the left, mobilizing with my right hand. If you found this video to be helpful, please like, comment, and also consider subscribing to our Ortho Knows YouTube channel. In addition, if you have any questions about not only this video, but anything related to the clinical orthopedic world, don't hesitate to add those as well. I also wanted to share with you 2 playlists that we've created. If you're interested in learning more about the shoulder complex and in particular assessment of the shoulder complex, we have upper extremity range of motion assessment, which of course includes the shoulder complex, as well as clinical strength testing. Thanks for watching.